Welcome, everyone. My name is Michelle Petri from Johns Hopkins. We're going to be talking about lupus. These are my disclosures, and these will be our learning objectives this afternoon. I want to start with a pyramid. You notice I put SLE at the top because I'm biased, but I wanted to start at the bottom of the pyramid. Just having a positive ANA, this is so common. 20% of normal young women have a positive ANA. So we don't want to think that having a positive ANA is abnormal. And what will happen that will make life much easier is there's now a pattern of ANA that equates with being normal. So I think soon the ANAs will start to be reported as abnormal or normal staining patterns. The next level is having a localized autoimmune disorder. That's not rare. About 10% of Americans have a localized autoimmune disorder, one of the most common being autoimmune thyroid disease. Rheumatologists don't get involved until the next level, undifferentiated connective tissue disease. It means the person has something to suggest systemic autoimmunity, perhaps ANA plus Raynaud's, ANA plus morning arthralgias, but they don't meet criteria for one of our named diseases, such as lupus or rheumatoid arthritis. We know that about 5% of women have an undifferentiated connective tissue disease. So again, not rare at all. Here are the criteria that we're now using to classify lupus, and I'm fine if you want to use these to diagnose. These were published in 2012. If someone has lupus nephritis by kidney biopsy, that's all you need. You don't need to count up any other criteria. But if there's not a kidney biopsy, then these criteria ask that the person have 4 things, at least one of which must be a clinical manifestation, and at least one must be an autoantibody. Here are the clinical manifestations. You'll notice the first 4 are cutaneous or dermatologic manifestations. The next 4 are different organ systems, and the last 3 are each of the hematologic cell lines. For example, for leukopenia, the cutoff is less than 4,000, but you only need to have it happen once as long as you're certain it wasn't caused by something else, such as a viral infection or a medication like azathioprine. And here are the immunologic criteria. We're stuck with having the ANA there. There's currently underway a revision of the classification criteria headed by the EULAR group, and they're going to make it mandatory that the ANA be 1 to 80 or higher. The problem with that is that we know that people who've had lupus for decades and have been immunosuppressed for decades can become ANA negative, but they certainly had an ANA at the beginning of their disease. Of course, everyone here knows that anti-DNA is one of the specific autoantibodies for lupus. The next one is anti-Smith. It's actually named after a patient named Smith in whom the autoantibody was first discovered. So I don't think it's HIPAA compliant, but I think it was very sweet to name the autoantibody after the patient. Antiphospholipid antibodies occur in over 50% of people with lupus. And then low complement, although not specific for lupus, such an important clue when we find it. And then finally, the direct Coombs test, the antibody against red cells. 90% of lupus patients who have the direct Coombs test will actually never manifest a hemolytic anemia. This is again one of the very specific autoantibodies for lupus. I want to go over the dermatologic manifestations. This will be the show and tell part of my talk. So sometimes when people look at this, they think this is the world's worst case of acne. But the reason we can be certain that in fact it's lupus is that the areas shaded by ultraviolet light are spared. But rashes on the face can be confusing. These lupus rashes don't happen the same day as the sun exposure. The rash that can happen within hours of sun exposure is polymorphous light eruption. Lupus rashes require that an immune complex form activate complement. This doesn't happen until the day after. These lupus rashes will last for many days to weeks until they're treated. The patient on the left-hand part of this slide shows a lupus rash. The person on the right-hand side has one of those localized autoimmune disorders. Which one? Right, alopecia areata, which has nothing to do with lupus. So on the left, we see the findings that are so typical of lupus. The hair is fragile, so it breaks off, especially around the frame of the face, and the hair strands are thinner than normal, so the scalp shows through. And here is the worst rash, discoid, or chronic cutaneous lupus. It can happen without systemic involvement, and it is very highly tied to smoking. It's so devastating because it affects the deeper areas of the dermis, so when it heals with hypo or hyperpigmentation, and the hair follicles are permanently gone. Now here's an example of lupus arthritis. And when you look at this, you're going to say, she pulled out a rheumatoid arthritis slide by mistake, because you can see the deformities, the ulnar deviation, the bent thumb. But it turns out that these are reducible deformities, nicknamed Jacquards, and they're due not to joint erosions, as happens in RA, but to tendon and ligament laxity. So let's start at the beginning. What actually causes lupus? I thought you'd like this cartoon. Figuring out the human genome map was easy. The hard part is refolding it. We paid millions for the Human Genome Project, so what did lupus get out of it? Well, we got these wonderful genome-wide association studies called Manhattan plots, and we discovered that our old knowledge about HLA genes was correct. They are the ones most highly associated with lupus, but many others were discovered. We're now up to 80 and counting. And we did learn that some of these genes which were identified map to the interferon gene signature. Turns out a whopping 50% of lupus patients do have the interferon gene signature. Lupus is actually half genetics, but we're not talking about mutated genes inherited in a Mendelian dominant or recessive mode for the most part. Those can happen sometimes in pediatric lupus. For the most part, we're talking about normal alleles, which simply lead to a more active immune system. We do know, of course, that there are major ethnic differences in lupus that are almost certainly driven by genetics. It's been known for many decades, for example, that lupus is both more common and more severe in African Americans. Well, if lupus is half genetics, it follows it must be half environmental. And ultraviolet light is the classic environmental precipitant, but there are many others, including some drugs, smoking, and environmental precipitants like silica, mercury, and even insecticides. For infections, the most common one is Epstein-Barr Virus. And this has been shown in multiple case families, such as here, where children who develop lupus had an astronomically high association with EB virus. But it's also been shown in longitudinal studies, such as the military sera repository, where military personnel who later developed lupus had their serum stored every year. And after EB virus, years went by, and then they started to manifest lupus autoantibodies. By the way, the lupus autoantibodies are present for 5 to 7 years before there is a clinical manifestation. So how does it start? This is work that was done by my boss, Anthony Rosen, and his wife, Livia. They show that the very first thing that goes wrong is at the level of apoptosis, programmed cell death. This is happening to all of us billions of times a day, and our macrophages know that if a cell is dying, it should be engulfed in an anti-inflammatory way with release of things like TGF-beta. But what happens in lupus is that the dying cells are engulfed in a pro-inflammatory way with release of TNF-alpha. The proteins to which lupus patients mount an autoantibody response are on those apoptotic cell bodies. That's where the ROLA, RNP, SM, phospholipid are, and that is their first exposure to the immune system. Then we have a feed-forward loop. What I'm showing you is actually the normal immune system, but it is revved up in a lupus patient. We think of lupus as the B-cell disease with B cells and plasma cells making autoantibodies that then form immune complexes that can activate plasmacytoid dendritic cells. The plasmacytoid dendritic cell is one of the major sources of interferon and therefore the interferon gene signature. But in the middle, you see BAFF, the B-cell activating factor, sometimes called BLIS, not for blissful, but B lymphocyte stimulator protein. Blocking that led to our first and only FDA-approved biologic for lupus, belimumab, or Benlysta. But think of this as an equal opportunity slide. We have multiple parts of this feed-forward pathway that we could interrupt to help lupus. Now, once this has gone forward, this revving up of the immune system, patients present. And people with lupus have two major patterns. One is to continuously have activity, such as always to have the discoid rash. But some patients have a flare pattern, perfectly well, and then the next day they're sick. And here's an example of one of my patients who had multiple flares each year. In research, but sometimes just in clinical practice, we can measure the overall activity of lupus using a physician global assessment. We can do this overall, globally, or within organ systems. We have more elaborate indices. Here's one called the SLE Disease Activity Index, which are weighted. So, for example, if there's neurologic activity, each manifestation is multiplied by 8. If there's renal activity, each part of that renal manifestation is multiplied by 4 to give a total over 100 if everything was active. I was teaching one of my fellows how to fill this out one day with the patient in the room, and I said, this is a very easy instrument. You just have to circle what's present, multiply it by the weight. You can do this in 30 seconds. This is the SLE die. And I'll never forget, the patient interrupted. Normally when we're teaching, the patients are listening very respectfully, and the patient interrupted by saying, Dr. Petri. I always know I'm in trouble when it's Dr. Petri. And I turned to her and I said, is something wrong? And she said, yes. She was really angry. She said, you never told me you could predict when I was going to die. And so that day I renamed it the SLE Day, the activity on that day. But here's the best way to think about what our outcome measure should be in lupus. Remember, it's good to be better, to reduce symptoms and signs, but it's better to be good. So this is the Lupus Low Disease Activity State, or LLDAS. And it means that the physician global and the SLE day better be very low, and there shouldn't be any major organ involvement. But it includes a limitation on prednisone. Prednisone must be less than 7.5. So this is our aim right now in lupus, to control disease activity, but not to have a high reliance on prednisone. Now why? Because the P in prednisone stands for poison. I say this to make us all feel guilty when we write those prednisone prescriptions. Of course, prednisone works, and it works fast, but our patients pay a terrible long-term price. If the maintenance prednisone dose is 6 milligrams or higher, the patient will have a 50% increase in permanent organ damage. The most common organ damage is osteoporotic fracture, and number 2 is cataracts. But it's even worse than that. The major cause of death in lupus is a cardiovascular event. If the prednisone dose maintenance is 10 milligrams, the risk of a cardiovascular event went up 2.4-fold. If the maintenance dose is 20 milligrams, which is going to happen all the time when we're treating lupus nephritis, the risk is over 5-fold. So what am I going to do? That patient with that flare pattern comes in with one of her flares. Maybe it's a skin flare, an arthritis flare, a pleurisy flare. I'm not going to say to her, I'm not going to treat you. Please go home and suffer. I need to use steroids for the flare pattern, but I want to give a burst of steroid, not a long-term maintenance dose. And we can do that with a Medrol dose pack or with an intramuscular injection of a long-acting steroid like triamcinolone. We can do this very successfully. This works for 90% of mild to moderate lupus flares. Now, what are our current treatment approaches? Because we have all these people with continuous activity for which a small burst of steroid is not going to be sufficient. Hydroxychloroquine has become our major background medication. You know that it helps skin and joint lupus, but we maintain patients on it for its preventive role. It prevents 50% of flares. It helps to reduce cardiovascular risk factors. It reduces thrombosis in those with antiphospholipid antibodies. And it is our only medication that improves survival. We have problems. We introduced blood levels to measure hydroxychloroquine and discovered that only 50% of our patients were taking it. And the cost has gone up, which seems absolutely ridiculous since this is a generic that's been around since World War II. But our other problem is that we've always said that retinopathy was very rare, and that's still true. There's no retinopathy in the first 10 years. But now that our patients are surviving longer, there is retinopathy that can occur after many decades. Ophthalmologists now have more sensitive screening tests. Here's one that's called OCT, for optical coherence tomogram. On the top, you see the normal pattern, which is the dip in the parafoveal pattern. Underneath, you see that the dip is gone, and you see within that dip the flying saucer sign. So this is pathognomonic for hydroxychloroquine retinopathy. And who knew that ophthalmologists have a sense of humor? There are going to be other very safe immunomodulators for lupus. One that's already been discovered is vitamin D. My work showed that we only needed to achieve a vitamin D level of 40 to have a significant reduction in overall disease activity and in particular urine protein. This has now been substantiated by a randomized clinical trial. Vitamin D may have a lot of other benefits in lupus, including cardiovascular and hematologic benefits. Cardiovascular benefits include a reduction in blood pressure and cholesterol. Since half of our lupus patients have antiphospholipid antibodies, a very important benefit is that vitamin D reduces thrombosis. And this was actually proven in a randomized clinical trial in oncology. We also now know from studies in pulmonary fibrosis that vitamin D is the poor man's antifibrotic drug. This may lead to greater use in people with lupus nephritis, many of whom do not do well long term. Over half of lupus patients will be on an immunosuppressive drug. We use many of them, and we tend to pick one over another based on the organ system. For joints, for example, we tend to use methotrexate the same way our colleagues do in rheumatoid arthritis. In pregnancy, we can only use azathioprine. For lupus nephritis, although mycophenolate and cyclophosphamide work equally well, we nearly always pick mycophenolate. We hated the old days of cyclophosphamide. Rituximab failed in 2 lupus clinical trials, one renal and one non-renal, but we still use it as a rescue drug. And then we have that one approved drug, belimumab. In lupus nephritis, we're going to do better because we're going to embrace multi-target therapy. Why do we need to do this? 1 year after starting mycophenolate for lupus nephritis, fewer than 50% of patients have achieved a renal remission. Problem we have with lupus nephritis is that with the very first event, the patient has already lost 1/3 of her nephrons. If we don't do something quickly, she's going to lose even more. The Chinese have led the way by adding tacrolimus on top of mycophenolate, just basically embracing a transplant regimen, but for lupus nephritis, and have shown much better complete renal remission rates. Now, obviously, we have to prove this in other ethnicities as well. And that has been done with the next generation calcineurin inhibitor, voclosporin, that has much better pharmacokinetics, so you no longer have to worry about peak and trough measurements, for example. You'll be amazed in this lupus nephritis trial, the prednisone dose was just 25 milligrams, showing you that even in lupus nephritis, much lower doses of prednisone are now being embraced. In the voclosporin lupus nephritis trial, the lower dose of voclosporin worked the best. This is one of the confusing things about lupus trials. Quite often, the lower dose works better, making us wonder if higher doses actually lead to changes in other pathways. Although the voclosporin patients did much better in terms of their renal response, this trial did have an imbalance of deaths in the low-dose voclosporin arm. No particular pattern, though. They weren't all infection, renal deaths, cardiovascular deaths. So I agree with the company that it was important to move on to phase 3. For non-renal, belimumab was our first biologic and now our longest studied biologic. Here you see the combined phase 3 trials, which showed that belimumab works best in those patients that have both low complement and high anti-DNA. There's a 20% delta in that subset. In a regression equation, it also works best in those with high overall disease activity and those that have responded to prednisone. A post hoc analysis showed that it works well in the two most frequent organ systems involved in lupus, joints and skin. It does reduce severe flares. This is particularly important because severe flares lead to a huge increase in prednisone and often a hospitalization. We now have very long follow-up of those patients who were in the clinical trials. Here you see that the SRI response is durable and even increases over time. There is prednisone reduction, and very important for patients and rheumatologists, no new safety signals with long-term follow-up. We're going to have more, so in about 2 years, we should have the anti-interferon alpha receptor blocker, or anifrolumab. If you're going to say that's too many syllables, we agree, and so people have started to nickname it Annie. Now here's another example of trying to get to good. So this outcome measure combined not just reduction in signs and symptoms, but being able to taper the corticosteroids. As you would expect, Annie only works in those that have the interferon gene signature. It worked not just globally, but particularly rapidly for skin and worked for joints as well. And then a really great story of perseverance. Peter Lipsky wrote an article for the journal Lupus where he looked at drugs and biologics that had never been studied in lupus and ranked them. And it turned out the highest ranked one that had never been studied for lupus was ustekinumab. And Janssen listened and did a phase 2 trial of ustekinumab for non-renal lupus, showing global benefit that was statistically significant, as well as benefit for skin and joints and benefit for serologies. So this phase 2 will now move on to a phase 3 trial for SLE. Now, one that I can't show you is baricitinib. There has been a press release that the phase 2 trial of baricitinib for lupus was positive, but the actual specific results have been embargoed and will be presented at the EULAR meeting in June. Now, this slide makes it look like the prognosis of lupus has greatly improved since 1950, where half the patients died within the first 5 years. But you see that the very top line is 1978. It turns out that the survival of lupus patients plateaued in 1980, and we haven't made subsequent progress. And this is incredible because we're talking about my generation of rheumatologists, where we do think that we've made a lot of advances in lupus treatment. But as you've now heard, lupus patients don't die from active lupus, they die from cardiovascular disease. And in my cohort, the risk is increased 2.66-fold over Framingham controls. A Canadian study showed that if we controlled for all the traditional cardiovascular risk factors, the risk of atherosclerosis and lupus would still be increased about 8-fold. We constructed a cardiovascular risk equation to predict the lupus factors that are involved, and they are global activity, a low C3, and the lupus anticoagulant. So we do know what we need to achieve if we're going to eliminate the lupus part of this cardiovascular risk. So what can we do right now? Well, we need to both assess and treat to target the traditional cardiovascular risk factors. Turns out hydroxychloroquine will help because it lowers LDL. Vitamin D will help because it lowers cholesterol and blood pressure. So some of our medications can help rather than harm. I actually thought that statins were going to be the answer, and that led me to do a 2-year intervention trial of statins in lupus that was completely negative. And in fact, statins don't even lower hsCRP in lupus patients. The pediatric rheumatologist did a very similar trial in children with lupus, same negative results. The final nail in the coffin, though, was mice with lupus. Statins don't even prevent cardiovascular disease in mice. So what does work? In mice with lupus, it turns out mycophenolate works. Now, we're not going to give mycophenolate to everyone with lupus because its risks are real. And even in those with lupus nephritis, we'd rather not have to keep them on it their entire lifetime. But it does give us hope that there will be safer drugs than mycophenolate that perhaps could be used lifelong. And of course, remember, keep the prednisone down. But sometimes I think I'm doing very well in controlling the patient's lupus, and they're not happy at all. I call that a nickel's worth of lupus, but a dollar's worth of complaints. So what's going wrong? Well, sometimes the patient is complaining of cognitive impairment. 10 years after diagnosis, Robin Bryce showed that a whopping 80% of lupus patients have cognitive impairment. In the brain connection study, we showed a big surprise. The cognitive impairment is present at the time of diagnosis. It's probably starting to happen in the 5 to 7 years where the person has autoantibodies, but they haven't reached a clinical manifestation that brought them to a doctor's attention. The good news was that once the person is under the care of rheumatology, we don't see worsening of that initial cognitive impairment. But the second thing that happens all the time is a lupus patient with chronic pain. And I'm here to say that lupus is not a chronic pain disease. It's an inflammatory disease mediated by autoantibodies. So what's wrong? Why do 1 out of 3 lupus patients have chronic pain? It really seems to fit the construct that we call fibromyalgia, and it may be why in our clinical trials we usually don't see a reduction in fatigue or chronic pain. So this is the mantra that I teach the fellows. If everything seems to be going well, you have obviously overlooked something. So what do we overlook? We overlook osteoporosis. One of my 18-year-old patients was getting off the bus one day, and she didn't even fall. She just put her foot down on the pavement and heard a crack. Then she put her second foot down, and the first leg cracked again. She had a tib-fib fracture without any trauma. She'd had lupus nephritis at age 6 and had been on high doses of steroids throughout her life. Nobody did bone density scans back then in children. Now we know that we do need to keep track of bone density in everyone who's on steroids with lupus. One of my other patients taught everybody at Hopkins an important lesson. She was 35, and her husband was off serving in Desert Storm, and her friend said, "We're going to take you out dancing. You need to have some fun in your life." And she started to have a little heartburn and said, "I'm not feeling quite right. I want to sit down." And her friend said, "Not only do you not look right, but we're taking you to the Hopkins emergency room." I did get a call. It was in the middle of the night, and the intern said, "We know you always want to hear when your patients are in the ER. It's nothing bad. It's just some heartburn." And we've given her some antacid. We're going to send her home. And I said, "She's still having the heartburn?" And he said, "Yes." I said, "Did you do an EKG?" And he said, "No." And so I gave him my 2-minute spiel about atherosclerosis and said, go back and take care of the patient. And then hours went by. And I didn't fall back asleep because I was so worried about her. And I finally got the second call, and this time it was from the chief resident in the CCU. And he said, "Don't panic," but her EKG showed some T-wave changes, and we gave her a nitroglycerin, and she felt better, so we decided to admit her. And when she got to the CCU, her very first rhythm was V-tach. She came that close to being sent home. So you will never forget atherosclerosis. But I want you to think about the lupus patient in total. They're on so many drugs, and I've learned that some of their drugs are contributing to their damage. So cardiovascular risk of NSAIDs is true in lupus. Proton pump inhibitors really do increase osteoporotic fractures. Lupus patients should be on H2 blockers instead. By the way, they also increase renal damage, and they increase dementia, and they increase cardiovascular disease. And finally, Hopkins published a study that had nothing to do with lupus patients, general population, showing that calcium supplements increase coronary calcium. This was part of the MESA study. So we want our lupus patients to get their calcium naturally. So I always like to end with this slide. This is St. Sebastian. Think of him as a lupus patient because our men with lupus fare the worst. They're the most likely to have renal failure, the most likely to have a myocardial infarction. I don't think St. Sebastian had to die if it was just one arrow. The lupus arrow doesn't have to kill anymore. But the cardiovascular arrow, the end-stage renal disease arrow, the opportunistic infection arrow, our lupus patients have so much comorbidity that we're a little bit like the Dutch boy with the finger in the dike. Let's plug up those holes. Thank you very much.